Respected chairpersons and my respected distinguished colleagues and friends. Today I am presenting about low intensity shockwave therapy for intractable erectile dysfunction. This we have been doing for last 8 years or so, and each year we are finding things are better, either because we have improved or the patient long-term follow-up has come, which is more encouraging than the initial years. We do it in two places. We have two different machines. Because first machine we purchased in Medipatnam, we were encouraged to took another machine. And initially when we started taking this, we were a little apprehensive whether it works, because many things come into the market, but generally they went away without much noise. We were also not sure, because the machine costing around 25 lakhs at that time. Still we went ahead, tried to do what best we could do with the machine what we have taken. It's a simple machine which could be accommodated in any small rooms, non-invasive, which is more attractive to the patient. But most invasive treatments, the patients of erectile dysfunction, they are discouraged because they are little secretive about it. No scar, no hospitalization, no other person should know. Even the person sitting next in the OP also should not know that he is having ED problem. So that sort of a scenario. This is a very privately you can do this machine, whatever sitting we are doing. We all know that the shockwave therapy works. 1977, Christian Chaussee has done on the kidney stones, which was successful, and it has actually ramified like anything all over the world. So we are doing the same thing with a shorter focal length. It is about 1/6 of the focal length of the shockwave that we use for the kidney stones. Because the organ is small, the organ is small, and then the target is very close to you. You can hold it. Like a kidney, we cannot hold and blast it. Whereas here you can hold it. See, what we are trying to do is the 2 crura and then 3 parts in the penile area. So these total 5 areas we are actually targeting. Each one for about 2 minutes or 3 minutes, and then 5 sittings, 5 places, total about 15 minutes procedure. Now, how often we do? Initially when we said multiple sittings, patient is discouraged, is upset because the first sitting itself has not given much results. We have found that at least if patient does more than 4 sittings, he won't find much difference. But we are advocating 12 sittings initially. Later on we found that it is difficult to convince a patient to go for 12 sittings. Only 6 sittings, it works or not, we will make a conclusion. So most patients are able to agree for 6 sittings. And twice weekly for 3 weeks. The advocated thing is after 3 weeks, you should actually give a gap of another 3 weeks, then come back for another 6 sittings, which itself was not very attractive for most patients. See how we are doing it there. We are targeting on the shaft. What happens here is there are some microcalculi, microliths, calcification, atheromas, like in heart. They are present in the penile organ also because both of the vessel of the heart as well as the penile area are same. So the disease of the heart almost always has a disease in the penile organ. So we are trying to blast the stones. And whenever there is a blasting of the stone or fragmentation of the atheroma, they get dissolved in the body, go back, and then the erections are very strong, which was found by the patients by early morning erection, not only by just subjective opinion, it is also by the IIF, Internal Index of Erectile Dysfunction. We did about 472 vasculogenic ED patients. We are very careful to select the patients who are vasculogenic only, not the neurogenic patients or otherwise. And the duration of erectile dysfunction, most of them were around 1 to 5 years. And the second criteria was rigidity scale. So we did a follow-up scan after 1 month. Initial penile Doppler showed like this. There were some sort of interruptions here and there. So it was improving. The diameter of the vessel was improving, and then the flow pattern was improving. So most of the parameters were good in 80% of patients, not all. So 78% of patients, we had good results. Another 20%, difficult to answer them. But still, we are always telling them that some people, if they don't improve, they have to go for other procedures. Like intractable ED, only 78 to 80% is our experience. Some reports have given more than 84%. So, how it improves is if a patient has spontaneous erections or a better response with a sildenafil tablet. So this was done at first month and third month, at the end of third month, and we found that most of the results were better. Rigidity scale also was improving. So you all know the scale. Scale 1 is the no erection, 2 is there was some erection but not enough for penetration, 3 is they are improving with the extent of penetration, which is very good. So if you see here, 368 patient out of 472 improved from score less than 2 to a score of more than 3, which is very good. So a non-invasive procedure which takes hardly 15 minutes in a secretive way, without hurting, without any pain or after effects, without contusions, is a very attractive option for patients with vasculogenic ED. If you don't select the patient properly, then failure rate may be high, because if you take up non-vasculogenic patients, the results may be poor. So initial suspicion or doubts about this machine have been dispelled that it works well in patients. And in fact, we have done some patients on Chrnnai disease also, where we are trying to crack the plaques. Results were not that encouraging as in a patient with vasculogenic ED. Still, this is a good option for patients with vasculogenic ED for a period of long term. The reported results are about 8 to 12 years after a successful result. Our experience only 6 years after the initial setting. None of the patients have come back to say that the problem has recurred. Maybe they are all right with a single tablet somewhere, but majority of patients have gone back and said they are okay. They didn't need an implant. The 20% of patients who did not improve, certainly we are given the other option of penile implants. Majority of them, they are Shaw implant we have put on them. Though there was initial some sort of a dispute-like thing that you didn't tell about this machine, it doesn't work. But the charges should be on the lower side, because if you fail after charging heavily, the dispute might be much more. So that's the summary, that the cost should be less. There should be good consent. There should be enough counseling about patient, what is going to happen, what he should expect from a machine like this. And some patients, surprising feeling what we have seen is, they have gone for 6 sittings, they went away. We asked them to come back after 3 weeks, they didn't come back. They came back after 1 year and said that, last time when you did 6 sittings, it was good. So we want another sittings. That way, we had some patients who came back for the second set of 6 sessions, which was also a good result. But if somebody does 12 sittings as advocated, the results are quite long term. Maybe 8 to 12 years, I don't know. There are others who have used this, should tell more, because our experience is 6 to 7 years till now. And since that time, we had very good response. Every patient who comes in and asks us, sir, is this a shockwave therapy? Which is, you are advocating a shockwave therapy on an organ which is so sensitive, which is so secretive, and you are putting shock on that. It's not a shock, it's a misnomer. There is no shock involved, it is just look like a vibration. When you say vibration, they say, we have vibrators at home which we use for the muscle pains. Not that sort of vibration. It's an electro-hydraulic shock wave which is generated by a scientific method where the focal point is fixed and every organ is not same. So we should know exactly how much depth the artery is and how much calcification is there. On the penile scan itself, we can know where are the calcific spots, and that sort of thing, if you assess and do properly, then only the results are good. Not just blanket treatment for everybody who comes with erectile dysfunction, it doesn't work. Majority of patients have already used Viagra, like a sildenafil or tarlafil, ended up with cavernous fibrosis. So those patients who have less dense fibrotic elements improve better. So totally calcific spots is not good.
Thank you, sir. Time is over.
Not a very good option.
We'll go to questions.
Thank you.